Welcome to the Desira Clinical Insights podcast, HIV viral blips, interpretation and clinical management in the era of modern antiretroviral therapy. Our guests today are Dr. Anu Hazra, Associate Professor, Section of Infectious Diseases and Global Health at the University of Chicago, Illinois, and Dr. Bahuma K. Tatanji, Assistant Professor, Department of Medicine, Emory University School of Medicine, Atlanta, Georgia.
I'm excited to spend sort of the next few minutes sort of talking about something that a lot of us in HIV care kind of struggle with, these blips and sort of increases in viral load that drive both us and our patients kind of crazy sometimes.
Yeah, it's a huge source of anxiety for patients and also sometimes for clinicians that are not deeply steeped in HIV care management. So
I'm excited about sort of going through some of the pathophys behind this and hopefully offering some reassurance, but most importantly, some sort of clinical tips of what to do when we come across a scenario. Maybe it'll be nice to maybe start with a clinical case that we can work through and go from there. So this is actually a patient of mine. This is very real to me. And so let's start with a 46-year-old male living with HIV who presents for routine follow-up in your clinic. He's been taking dolutegravir-limiting fixed dose combination for the past 2 years and has maintained consistent undetectable viral loads per your assay, which detects below 50 copies per ml. He reports excellent adherence, rarely misses any doses, and has had no recent changes to either his HIV medications or any other medications on his record. At today's visit, he feels well, has no new concerns. It's just a routine sort of visit. His CD4 count is 680 cells, which is sort of his normal amount. But when his laboratory results return, his viral load is at 113 copies per ml. Before even we are able to contact him about these results, he checks his portal and sees sort of a red flag and immediately messages you and says, I've been undetectable for years. Does this new value mean my medications are failing? Do I need resistance testing or a completely brand new regimen? So obviously, anxious and concerned. So BK, does this sound familiar to you at all? Is this a case that resonates with you at all?
absolutely. I've had the exact same scenario happen to a bunch of patients of mine. And I think when we're dealing with the fact that sometimes patients are now able to see their results even before their clinician notified of them, then you deal with instances where you have a patient maybe panicking over a result that may not warrant that level of anxiety. So I think, a really good place for us to get started is just to lay out the definitions of what is a blip and, when should patients panic?
I think definitions are important to sort of level set so we're all on the same page. And I think it's also important to not only sort of educate providers about these definitions, but also patients. So then they also have this information as well. So let's go through some of these definitions and terminologies as we talk about sort of blips and viremia. So, a viral blip by definition is a single detectable HIV RNA. Typically, a blip is under 200 copies per ml. And the point of a blip is exactly that. It goes up and comes right back down. And so you have just an isolated increased amount of your viral load and comes back down to undetectable without doing anything else. So it just goes up and comes back down by itself. And we'll talk maybe a little bit about why blips happen, but that's what a blip is. Now, what is persistent low-level viremia? So if someone doesn't just have a blip, goes up, and then remains at sort of that level for a while. So we consider low-level viremia as anything under 200 copies per ml. Remember, our assays for PCR testing has become so sensitive, but we consider sort of low-level viremia as anything under 200 copies per ml that remains, it's not a blip that comes back down to undetectable, but remains at this sort of persistent low-level viremia, sometimes abbreviated as LLV. And then virological failure is sustained viral loads that are above 200 copies per ml. Important to note, this is the United States threshold. The WHO has a separate threshold for what they consider to be virological failure. But here in the United States, where we practice, a viral failure would be an elevated viral load above 200 copies per ml. Now, undetectable is something that is important for us to pin down, specifically as it pertains to U equals U and how that's a huge part of our messaging to patients and how we think about undetectable equals untransmittable. Now, undetectable on your assay may depend on the type of assay you have. Some assays go down to 13 copies per ml now. Majority of the assays are at least at 15 copies per ml. So you could have an assay that's undetectable, but what does it mean for U equals U or to be functionally undetectable, meaning that you're able to harness the power of U equals U that eliminates the transmission? We define as under 200 copies per ml. So anything that's under 200 copies ml, we are using this terminology called functionally undetectable, and maybe, you can preserve your undetectable to be sort of equivalent to what your assay shows in general. We have sort of guidelines to think about. So in the United States, when we think about suppression or sort of sustained virological suppression, we really use that 200 copies per ml as our sort of threshold. The WHO uses 1,000 copies per ml as their threshold. And there is, obviously a growing body of evidence that U equals U can likely be pushed to 1,000 copies, and anything under 1,000 copies to be undetectable for untransmittable. But we continue to really preserve the 200 copies here in the US. And again, thinking about sort of functionally undetectable versus what your assay says to be undetectable, not all detectable virus means it's a treatment failure, and hopefully our conversation can go through that. And again, it's more than just a single value, and this is in medicine in general. Right? We're not chasing a number, we're chasing a pattern or a concern that we have or a trajectory of where things are going. But yeah, with sort of level setting sort of these definitions, BK, I'd love to hear sort of your take on, why blips happen, when do we see them, and sort of what might be some of the biology behind this.
Yeah, I think that that's usually the immediate question when you've had the conversation with a patient about what the levels of detection are and what the thresholds and the definitions are. They want to know, why do I have a blip and why does this happen? You already went over one of the main drivers, which is the assay variability. So a blip in my clinic, that when we use an assay that has a detection level of less than 200 copies, may be different from a blip in a clinic where they're using an assay that has a detection level of less than 13 copies. So, in my clinic, someone who shows up with 67 copies, for example, will not be considered a blip because on my report, they will be marked as undetectable. Whereas in another scenario, using a more sensitive assay, that clinic may flag a blip. So the assay variability is one of the drivers of these differences that patients can sometimes see in their report. But there are true biological drivers of these detectable viremias that can be seen in patients. One of them is anything that activates the immune system. And I'm particularly thinking about things like viral infections. You may have a cold and you're someone living with HIV who has been undetectable for years and years and quite stable on your treatment, but having an acute infection, be it a viral infection or bacterial infection, can activate the immune system. And when you have an activated immune system, those resting CD4 T cells that are the viral reservoir can be activated to become cells that are capable of churning out virus. And that can cause a blip. And we oftentimes see these types of blips, for example, when patients are acutely ill and then someone checks a viral load on them.
Right.
So that's one of the drivers is anything that leads to a pro-inflamed state. So an acute illness or even a stress situation, like if you're undergoing a period of stress and your immune system is activated by that, that could result in a transient detection of your viremia. There's also the whole idea of clonal expansion. Again, that viral reservoir is your CD4 T cells that are resting. And because the pool of CD4 cells that everybody has is maintained by those cells replicating themselves, in your CD4 cells that are the reservoir, they can replicate themselves to maintain your pool of CD4 T cells. But when they do that, they copy exactly also the proviral DNA that was existing in the mother T cell. So in expanding your pool of T cells to sort of maintain that pool of cells, they expand your reservoir. Sure. And again, whenever these cells are activated and churn out virus, you can get a detectable viremia. But it's important to note that not all detectable viral RNA is actually viral RNA that can cause an infection. Sometimes it's just pieces of viral RNA. But because the assays are so sensitive, they pick these things up and that can show up as a blip. And then the last thing that I wanted to talk about is also, adherence, particularly of daily regimens, is not always perfect. And sometimes you might have an individual who has missed one dose per week or a couple of doses over the course of a month. And that may also lead to low level viremia if you time their viral load testing
That's
close to one of
unfortunately
those
wrong. Yeah.
missed doses. But I also want to just stress that, in the context of the medications that we currently have for antiretroviral therapy, these are very potent regimens, particularly with integrase inhibitors that are the backbone of a lot of these regimens. Blips tend to occur less frequently. And we can't stress enough the importance of having a trend as opposed to fixating on just one single value. And that the same goes for long-acting antiretroviral therapy because it impacts on adherence, but it also contains medications that are very potent. And I think it's important for those clinicians that are listening to us to take away from this conversation that the majority of blips that they would encounter are benign. And when you recheck, it usually goes back to the undetectable viral load that is expected on someone who is taking their medications as prescribed.
Yeah, yeah. Thank you for walking us through sort of a really complex topic in a very straightforward way, BK, because I feel like when we experience these blips, particularly in the community, there's this urge to like intensify the regimen, to add another drug on or change people off of ART. And all the guidelines, DHHS and ISUSA, say no, to hold steady in the setting of just a blip, to continue to monitor. And like you said, BK, not reacting to a single value, but really trying to step back and looking for a trend, a pattern, and whatnot. Thank you. Yeah, I mean, I think, going back to our case, so we had this, otherwise healthy individual living with HIV on a 2-drug regimen, which already might make some people nervous about sort of what it means in terms of virological control, and that might be a whole other podcast. But let's say, yeah, so, he's just coming in, routine follow-up, otherwise healthy, not ill right now. And he has, he's been undetectable per your assay. So let's say our assay is under 50 copies per ml, and he's always been under 50 copies this entire time, and now comes in with 113 copies. What do we make of this? Is this something that we need to sort of act on? Is this something that, how would you handle this in your clinical setting, PK?
I think the main response to this 113 copies is primarily calling the patient to reassure them.
Yeah.
That this is not unusual. This is not something that should trigger panic, and then tell them to continue to take their medications and plan a recheck at their next visit. And when I have these conversations, I always go back to stressing on the U equals U threshold, because really when patients are anxious, that's usually what they're worried about.
Right.
They're worried about, is this going to mean that I can then pass on the virus to someone else? Is it going to mean that my T cells are going to suddenly drop? So I really focus the conversation on these elements to reinforce the messaging that no, you're good, and we can recheck. Now, another question that frequently comes up is, do we need to recheck immediately?
Right.
Personally, in my practice, I don't feel the need to recheck immediately.
Yeah.
Because by definition of a blip, I know that when I recheck,
it'll come back down.
It should be back to where I would expect it to be. So I don't recommend calling the patient back into the clinic and disrupting their schedule just to recheck, because that you had one blip. I would just say at their next scheduled visit, if it's in 6 months or in 3 months, when you get labs, it's okay to recheck at that time.
Exactly. And sometimes patients may themselves ask to be rechecked, at a certain time. And this is very similar to how we think about sometimes like syphilis screening, where people want to get checked for their RPR immediately after treatment and whatnot. And I try, I think it's a patient-centered discussion, right? So it's shared decision-making in terms of what's important. If the patient is really anxious and really wants to see that number back down, certainly you can, recheck or whatnot. But I think, to your point, BK, it's like a blip is exactly that. So you would expect it to come back down. So there's no clear indication that they need to come back for a second sort of viral load earlier than when you have wanted to recheck subsequently. And yeah, I think this patient education is really important in the era of open records and portals and whatnot. It causes a lot of anxiety for patients, and that anxiety is contagious to like your clinic staff and the people answering those messages. And so I think really having clear definitions that you're able to provide to patients, and then this idea that you are functionally undetectable, that the function of U equals U remains even if your viral load is now somewhere, between, 50 and 200 or 20 and 200. And in fact, as our assays are getting even better, there's this like ultra low viremia, which is between 20 or now 13 likely and 50. And really, is this a clinically meaningful number? And, many of us would argue that no, I don't think there's any clinical meaningfulness between someone having viral load of 24 and then having viral load of 45. And to BK's point, like we've seen with COVID and a lot of other PCR tests, that just because a PCR is positive doesn't mean there's active pathogen that can cause disease or issue based on that. Let's change our scenario up. So what if, BK, this is someone, the same patient who is hospitalized for, let's say, acute cholecystitis, and the surgeons are about to take him out for a lab chole and decide to check his viral load before the OR, and like before, he's on lamivudine dolutegravir, has been undetectable, and now let's say his viral load is 163 copies per ml. You get a call from the hospitalist who's panicking and saying, hey, we need to get his viral load undetectable before they can go into the OR. Do we need to change a regimen? Do we need to get a resistance assay? How would you handle that type of sort of inpatient scenario?
Yeah, these inpatient scenarios are not infrequent because, unfortunately, when our patients or people living with HIV come into the clinic, one of the few tests that clinicians who are not necessarily familiar with HIV care remember to order is the CD4 count and the viral load.
Yeah.
And I think that they don't always process the component of the information that this is someone who is acutely ill and translate that into the fact that they might have detectable viremia that they then have to have a conversation about. So the conversations I have in this type of scenario, I usually take this as an opportunity to provide that education for our colleagues that are more likely to be seeing these patients who are stable and coming in for something else that's not related to their HIV status. And I provide reassurance that it's not unexpected, that they have a blip, and that it's entirely safe for them to proceed with whatever treatment is determined to be appropriate for their acute condition. And I think in the case of this particular scenario where, again, you're talking about the surgical team maybe being nervous because someone has a detectable viremia, I go back to that U equals U threshold, saying, this is a blip. This person is going to continue taking their HIV medication while they're inpatient. And the risk of transmitting it to someone else, even in the context of a needle stick injury, will be quite low. And we know that our surgical colleagues are taking all precautions anyway when they have these procedures. And thankfully, needle stick injuries remain a rare occurrence in the hospital as opposed to something that happens on the daily.
Right. And nosocomial acquisition of HIV from patients to healthcare providers is sort of a completely rarefied event now in 2026 and not something that we are concerned ourselves as much with. But obviously, for folks who are not as involved with the, caring for people living with HIV, it remains a concern. So there's multiple layers of education that you're doing in this setting to the patient, to the care teams, to the surgical teams as well. So let's shift gears and say, so when would we actually care? When would we actually want to delve a bit further? And I would argue that, whenever I see a change in a viral load, I do still ask some follow-up questions, right? So I still ask, like you mentioned, BK, about adherence, right? About Yeah, if they're on oral ART, like tell me, you told me you didn't miss any doses. Let's think about it right before, we saw each other. Did you miss any doses in the past week or the past month? It's easier to sometimes give a defined period of time for folks to be able to recall what that is. If they're on long-acting injections, I do ask, did you notice like any of your recent injections feeling funny or feeling different or not being the usual? But sometimes it's important to ask about other drugs that make. And while there might be not any changes, let's say this person, so for example, in this case, let's say that he's been having a lot of indigestion recently and have been taking a lot of Tums, that he's been taking multiple Tums on a daily, on a multiple times a day basis, in addition to his dolutegravir and lamivudine. Is this something that, something that we would be concerned about in the setting of, a newly positive viral load?
Yeah, I think that you bring up a very pertinent point because, sometimes when we have those conversations, we fixate on the adherence issue
Right.
and we forget that there are actually over-the-counter medications that can interact and reduce the absorption of these antiretroviral therapies. So it's always very important to do a thorough med rec of the stuff that we've prescribed as opposed to, and as well as the supplements that patients may have decided to get over the counter for other indications. Because in these instances, if someone, for example, is taking a calcium-based supplement or is taking an anti-acid medication, these classes of medication, which are available over the counter, can really reduce the absorption levels
Yeah.
of some of our antiretroviral therapies. And I usually ask patients, how are you timing this? Are you taking this right alongside, using your Tums to swallow your
Right.
therapy pill,
Or you
or
can
are
keep
you
it down.
giving it
Yeah. Yeah.
exactly a 2 hour spacing
Right.
between whatever over-the-counter drug you're taking? And sometimes that would allow you to identify instances where the potential for drug interaction is real.
Yeah.
And in those settings, then I worry a little bit more about that blip being something that than just transient.
Right.
So I educate the patient on the importance of not taking the supplement or the
Yeah.
drug with their ART or appropriately spacing it. And I would tend to recheck that viral load a little bit sooner. But I
Yeah.
want to do it when they are taking the ART as prescribed, so
Right.
that what I'm seeing is an actual reflection of, taking medication as prescribed and adhering to therapy, as
Yeah.
opposed to just rechecking on the same day where they still took the Tums and took the.
Exactly. Yeah. And I think this is also really important in the setting of like low level viremia, where someone is consistently floating like under 200. And so this is not just a blip, but it remains as low level viremia, which could completely be clinically insignificant. But sometimes if you don't ask the right questions, maybe there have been sort of over the counter medications that are interacting. And this is also when, your ID pharmacist or HIV pharmacist are incredibly helpful. Because I've gone to my HIV pharmacist often and show them sort of this trajectory and like, hey, this is really confusing. Like, and then they can sometimes, elicit more information out of that patient that can actually clarify, a root cause of what might be causing that low level viremia in general. I mean,
And
oh yeah, go.
yes, I was going to add to that a couple of years ago, several years ago, I had a scenario with a patient who had a surgery that essentially developed short gut syndrome.
Okay.
And that accelerated, impacted on the absorption
Yeah.
of the medications. And
Yeah.
that was the only thing after extensive questioning that could be identified as what was potentially explaining the fact that they had low level viremia, because this wasn't a one-time blip,
Right.
but it was persistently low level viremia. And so we had to think creatively about changing that person's regimen with the support of our ID PharmD team that, helped identify what medication would be better suited in
Yeah.
each scenario. And it did resolve the issue. So,
Yeah.
very important to think out of the box and
Yeah.
ask the right questions.
Yeah. In a situation like that for like low level viremia, would you get archive resistance or like a proviral DNA? What are your thoughts on sort of thinking about more diagnostics in that area? And let's assume that this is a low level viremia defined as under 200 copies per ml.
Well, again, it would come back to the sensitivity of the assays that we actually have for doing genotyping testing. For most of the available assays that we have to actually do drug resistance testing and evaluate whether there's archive resistance contributing to this, the threshold is way higher than the level of 200 copies per mil. Ideally, to be able to do a genotype with our commercial assays, you have to have about 1,000 copies detectable. So a lot of these folks are presenting at very low levels. Now, if, for example, they were to have access to, say, a research laboratory that can do genotyping for a little bit lower copy numbers, the question is always, what does archive resistance mean in the context of low-level viremia? Is this actually something that we should chase and have the patient worried about? And there are studies that show that in the context of very low level viremia, below that 200 copy number, it doesn't matter much, even if you went to do a super sensitive research based assay and detect archive resistance. That doesn't mean that the treatment is failing because the patient's viral load is still below a level that, places them in a safe zone where they cannot pass on the virus and where their immune system is not going to get compromised because they have that low level viremia.
Yeah. 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 I mean, I think that's a really great point. I think, there was a consensus paper out in Lancet ID within the last year that kind of sort of tackled this idea of archive resistance. I think a lot of folks, I mean, this concern folks have about how to interpret archive resistance, I think has been sort of reignited with the advent of long-acting ART. And a lot of folks who want to transition from oral ART to long-acting that don't have the opportunity to ever get a genotype because they've been suppressed for so long. People have brought the idea, can archive resistance sometimes help us, figure out who would be ideal candidates? And I think that consensus paper really pushed back hard against that kind of practice and recognizing that there are clinical limitations to archive resistance. They can be a very interesting way to know what the historical, mutations that someone might have accumulated over time, but the clinical applicability of those results are yet to really be seen. And making sort of actionable clinical decisions on archive resistance is heavily discouraged when you have other data at your disposal to be thinking about.
Absolutely.
All right, so let's I guess wrap this show up, BK. So I guess if you had to give your sort of key takeaways of how to think about viral blips and low level of viremia, what's your sort of your top line approach to clinicians who might be listening to us right now?
I think that I always like to start by the fact that a single value should not be what clinicians use to make a decision. Trends are more important than single values, where virological blips are concerned. So if you get a patient that shows up with a blip and has a detectable viremia, your first instinct should not be to think about reflexively making a clinical decision on that. You should go through a short algorithm in your head, which is, what is this blip in terms of where it lies in my threshold of worry? If it's less than 200 copies, you provide reassurance to the patient and you have a conversation about the timing of rechecking. It's always important to do important clinical review on the MedRec and also ask the patient if anything has changed in the way in which they're taking their medication, just to make sure we're good on adherence as well as drug-drug interactions. And it's also important to remind ourselves that if a patient is presenting with a cold, that may not be the best time to be checking random viral loads on them, because in those scenarios, we're more likely to pick up on some of these blips. So the core message here should be reassurance, both for the patient and both for the HIV provider, and remembering at what threshold to do additional testing and to more aggressively pursue whether you're dealing with virologic failure.
Yeah, I love it, BK. And again, like communication is key in this era of open records. I think it's important to frame what a viral load means to a patient very early on to let them know that, hey, like we're checking a viral load. Any number under this number, under 200 copies per ml, means you cannot transmit the virus at all, even if your number might be somewhere between 0 and 200. Understanding the power of equals U still holds in general. And I think, again, being able to continue to educate colleagues as well that you get consulted on in the hospital or get curbsides on, and continuing to spread the message of U equals U and understanding that a more nuanced approach to how to think about viral loads is really important. And yeah, I think this will continue to happen as our assays get even more and more sensitive, down to even fewer and fewer copies. But I'm hoping this idea of what means to be functional and detectable kind of takes hold, and we can continue sort of utilizing that as a nice benchmark of how we think about ongoing treatment suppression for individuals. Yeah,
And
yeah.
I'll just add one more thing in terms of like the language that we use as providers. I think that when you use language that can cause alarm, a patient is more likely to latch onto that. So just avoiding terms like failure
Yeah.
when discussing blips, and just, calling them blips.
Yeah. Really great point. Well, BK, thank you so much for joining me and having this awesome conversation. I learned a lot from you, and I hope the listeners have maybe again a more nuanced approach of how they think about sort of viral blips and low-level viremia, and can take it into their practice. Thank you all for joining us.
Same here. Thank you all.
Thank you for listening in to our podcast on HIV viral blips.